Welcome everyone to the CTSNet webinar and the guest editor series, Segmentectomy for Lung Cancer, curated by guest editor Alan Seho. Thank you for joining us. Please note this webinar is being recorded and will be available Monday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce CTSNet guest editor and moderator of this webinar, Alan Seho. Dr. Seho is a former chief of thoracic surgery at the University of Hong Kong Shenzhen Hospital and is currently an honorary consultant in cardiothoracic surgery at Gleneagles Hong Kong Hospital. His current academic positions include Associate Editor for European Journal of Cardiothoracic Surgery, Thoracic Surgery Section Editor, Asian Cardiovascular and Thoracic Annals, Council member for the Asian Society for Cardiovascular and Thoracic Surgery, and board member for the Asia Thoracoscopic Surgery Education Platform. Welcome, Alan. I'll turn it over to you.
Okay, well, thank you so much for that kind introduction, John, and welcome everybody to this webinar. I'd like to thank, first of all, Mary Hammond and everybody at CTSNet for helping us put together this really important series. It's important because I think everybody who's tuning in tonight will know that segmentectomy is potentially the biggest thing for lung cancer surgery since the advent of Vats. It has a potential to revolutionize how we manage early stage lung cancer. I think last year, there's probably no trial that affected us so much as the JCOG 0802 trial, which showed not only was segmentectomy equivalent to lobectomy in selected patients, but potentially even superior. And of course, just this week, we've had the announcement of the Calgb 140503 trial results, which again further confirms the status of segmentectomy. So whether you like it or not, I think segmentectomy is going to play a huge role in our practices from this day on. And therefore, this particular series really comes at the most opportune time. I think I'm really, really honored to have these excellent speakers from literally every corner of the world, giving these video presentations on different aspects, key aspects of segmentectomy for you today. So I'd just like to introduce the video presenters in this series. So from Sydney, Australia, we have Dr. Christopher Chow. He's a very good friend. He's also a consulting cardiothoracic surgeon at the Royal Prince Alfred Hospital and the Chris O'Brien Lifehouse Institute in Sydney, Australia. He's a master robotic surgeon, but more importantly, I think most of you around the world will know him for his unparalleled quality of his systematic reviews. I think a lot of our current practice today, whether you realize it or not, are driven by some of the systematic reviews and meta-analyses that Christopher Chow has written. We also have Dr. Dominique Gossot, who again probably doesn't need any introduction. He's the former head of the thoracic department at the Institut Mutualiste Montsouris in Paris, France. You will know him as one of the pioneers, the original pioneers of Vats lung surgery. He's maintained that role to this day, and he's actually founded one of the most important sublobar resection conferences a few years ago in Paris, and this is now taking place around the world. So do pay attention to Dr. Gossot's annual conference on sublobar resection. We also have with us today Dr. Ricardo Terra. He's the chief of thoracic surgery of at the São Paulo State Cancer Institute. He's an associate professor of thoracic surgery at the University of São Paulo in Brazil, and he's a scientific director for the Brazilian Society of Thoracic Surgery. And we also have Dr. Jessica Donnington, professor of surgery and chief of the section of thoracic surgery at the University of Chicago. She's a council member for the Western Thoracic Surgical Association and a past president of the New York Society for Thoracic Surgery and for the Women in Thoracic Surgery group. We also have two other speakers, video presenters, who unfortunately couldn't join us here today. We have Professor Calvin Ng from the Chinese University of Hong Kong, a very close friend. He is one of the leading pioneers of uniportal surgery. He's working with some of the latest cutting-edge technology in thoracic surgery today, as you'll see in one of his videos, including navigation and location devices, ablation for lung tumors, and so on. And last but not least, we have my brother, Dr. Diego Gonzalez Rivas. Again, you don't need any introduction for him. He hails from A Coruña, Spain, and he's also a guest professor at the Shanghai Primary Hospital. And he, as you all know, is the creator of the uniportal Vats lobectomy technique. So we have a star-studded cast. I urge you all to pay attention to the videos, but that's just the introduction. Today, what we have for you in this webinar is a roundtable discussion with our speakers who will be talking about their video presentations. We'll have a discussion on some of the key topics around segmentectomy for early stage lung cancer today. I just want to remind everybody who's joining us live today that please feel free to ask any questions for any of the speakers at any time using the Q&A function in Zoom. And at the end of this session, we'll try our best to answer any questions that you may have. So with that in mind, let's get launched into this discussion. So in order of the videos as they were presented on CTSNet, I'd like to first bring my friend, Dr. Christopher Chow, into this discussion first. So Chris, if you can unmute yourself, we've given you the video on segmentectomy versus lobectomy, the clinical evidence, a hugely important topic. So could you just give the audience a quick summary of what they can expect from your video?
Sure. I just want to firstly thank you, Alan, for your generous invitation to this excellent panel. And it's a huge honor for me to be in the midst of my esteemed colleagues. In regards to my video, I looked at the existing and previous evidence, really comparing lobectomy versus segmentectomy, the most important of which originated, I suppose, 20 years ago, the lung cancer study group trial that really involved patients who were operated on in the 80s. And the paper itself was published in the mid-90s, but they really established the dogma that's being accepted standard of care in Western countries, at least over the last 40 years. And that dogma is really being challenged, I have to say, by the Japanese mostly, who did a lot of tremendous work in the 90s and 2000s. When we examined this particular topic 6-7 years ago, we looked at the existing literature. All of the studies comparing intentionally treated patients who had segmentectomy versus lobectomy originated in Japan. And there were about 6 studies that looked at the evidence at that time. And even then, they were able to show in very selected patients there were no significant difference between overall and disease-free survival for these 2 treatment groups. And this was followed by the JCOG study, which was published earlier this year in The Lancet, which was a very ambitious but ultimately successful trial with very uncompromising study design and very meticulous and safe surgical operations performed by surgeons, as well as very strict intraoperative pathological assessment. And this trial, I think, really sets the standard and can be regarded, I suppose, as a trial of the decade for thoracic community that demonstrated, somewhat surprisingly superior overall survival in the segmentectomy group. I think in terms of the what's on the horizon, well, I think just a few days ago, the Calgb trial has updated their outcomes. And I think that'll be of great interest in the near future to closely examine the patient cohort and the detailed analysis of that particular trial. So in my video, we'll go through some of the strengths and limitations of these 2 important recent trials, and also look at it from a historical point of view from the lung cancer study trial.
Yeah, I've seen your video. It is absolutely essential viewing for anybody doing segmentectomy today. And as you said, there are strengths and limitations. In terms of strengths, since 1995, we've obviously come a long, long way. Do you think at this moment in time, the evidence is strong enough, compelling enough that we should declare segmentectomy to be the approach of choice for selected patients?
Look, I think the key statement there was the selected patients. And I think in some ways, the JCOG study really justified the performance of segmentectomy as an intentional selection, rather than just limiting it to the compromised group of patients with comorbidities or limited lung function. I think also it's a bit of a gray zone in terms of patient selection. For example, in my clinical practice, I am more comfortable in providing a relatively younger patient with preserved lung function who's got a small peripheral lesion with a segmentectomy than a lobectomy. But I do think there is an inert sense of I suppose, conservativeness amongst the thoracic surgical and medical communities to stay with the lobectomy for many cases, as it will take time for people to accept this new paradigm shift.
Yeah, so obviously there's still some questions to be answered despite the evidence. So having reviewed the evidence, the current literature in this topic, what do you think are the limitations? Where are the gaps that we still need to fill in terms of clinical research?
Sure. I think we firstly addressed the JCOG study, and as I said, it was a very absolutely fantastic effort by the Japanese. But I think the two issues that came to my mind when I read the results were, one, were the results applicable to Western populations where I practice? That is to say, can you extrapolate this data to a different population? And also, in some ways, different surgical practice. I mean, they were very, very aggressive in their intraoperative frozen sections, and that is not ubiquitous in Western countries or anywhere. And the number two question, I think, is a question that's been really kind of put under the microscope, which is how do you reconcile the unexpected finding of worse local regional control, yet superior survival in the segmentectomy group? And, they've postulated a few different potential reasons, such as, more deaths from a second cancer in the lobectomy group and deaths from cerebrovascular disease and respiratory diseases. But it was still one of those things that wasn't intuitively, forthcoming when you look at the results. And so I think those two issues, the applicability of the results to different populations, and also how do you explain this unexpected finding? But really, it was relatively nitpicking to what it was otherwise a very fantastic effort by the Japanese. The limitations of the Calgb trial is a different issue entirely. I think, really, I personally think they may pose more questions than answers with the results that they have presented. And that is to say, if they do support the fact that sublobar resections are similar to lobectomies for these peripheral small lesions, I think it's going to be difficult for people to interpret the inclusion of the wedge resections with the segmentectomy group. And the concern there is that these results may be misinterpreted or still misled by surgeons and others who would argue that a wedge resection is just as good as a lobectomy, which I think many panelists here would disagree with.
Yeah, I think on that point, it is a time to bring in our other panelists. So we have really experts from all around the world on segmentectomies here. So do any of our other speakers have any comments on what Chris has just said?
I think I was intrigued by one thing he said, and that was the difference in local recurrence and overall survival. And I guess I'm wondering whether this trial is bringing forth the concept that maybe local recurrences are quite salvageable, and that it's not the same thing as a distant recurrence in terms of impact on overall survival. I have gone back and done completion lobectomies in people who have recurred after a segment, and now they're many years out. But with good surveillance, is local recurrence not as bad now that we have things like SBRT or the ability to go back and do a completion lobe?
Yeah, that's so true. I think the JCOG trial, a lot of their deaths in the lobectomy group were due to other cancers other than lung cancer, and that kind of was a bit spurious. But Dominique, do you have any comments? Oh, sorry.
Well, I think the sorry, I'm getting my airplane out. I think that the major issue with the JCOG trial, well, there are two issues. One is the excellent results in terms of survival, but the other one is the high rate of local recurrences. And that raises the question of how we are performing segmentectomies, and this will be something to study in the near future. Is first, what do we do with intersegmental lymph nodes? So are we examining the lymph nodes intraoperatively by frozen section? And I think as far as I know, it was not always done in the Japanese trial. And the second point is the margins. So probably we have many data showing that theoretically segmentectomies exposes to more local recurrences because when you study specifically the lymph nodes inside the lung, you have always overlooked metastatic lymph nodes. So these lymph nodes, they are removed when you are performing a lobectomy. Maybe they are not removed when you perform a segmentectomy. One of the ways to reduce this high rate of metastatic lymph node is to study the lymph nodes that are at the foot of the segmental bronchus. And I think this should be a rule in the future if we want to develop a safe segmentectomy program.
Chris, you were about to make a point.
No, I was just saying in regards to Dr. Donnington's statement about...
I have no sound.
Yeah, it's okay.
Yeah, I was just saying in regards to Dr. Donnington's statement regarding the ability to deal with local regional recurrence. That's absolutely right. And I think the JCOG study has come out with some data in the supplementary material in regards to how many patients went back for a second operation, whether that be a completion lobectomy, and they did mention that the segmentectomy group had a lot more interventions to deal with either local regional recurrence or a second lesion than the lobectomy group. And I think Dominique's point regarding intraoperative frozen section, it's a very good question, because I think a previous webinar, also on CTSNet by Joe Dunning, stated that every single patient in the Japanese trial had an intraoperative frozen section of all the lymph nodes. And I really just don't think that was true. And in fact, my pathologist contacted some of the members of the Japanese trial, and they said after a lot of research, they weren't exactly able to state how many patients had how many lymph nodes frozen sectioned. If you look at the text in the publication, it said if they were macroscopically suspected to have metastatic disease, then they had underwent intraoperative frozen section. But I don't know about you, but I can't always tell macroscopically which lymph nodes are involved and which are not. So what I do is just take the most sort of the sump and one lymph nodes at least. But how often you look, how hard you look, will really depend. Will really determine how often you would upstage and convert to a lobectomy.
Okay, I think in the interest of time, we'll move on to our next featured speaker, which is Dr. Dominique Gussot, the godfather of Vats in Europe. You made a great point, Dominique, just now about the technical aspects of doing a segmentectomy to achieve the best results. And that, of course, comes down to the anatomy, which is the focus of your video. Again, this is absolutely a very important video for anybody performing segmentectomy today. So, Dominique, could you tell the audience again, what are the main take-home messages from your video?
First of all, I'm not an anatomist. I'm a thoracic surgeon. And as all thoracic surgeons, I thought I knew quite well the anatomy of the pulmonary elements. And when I embarked in this program of segmentectomy about 10 years ago, I realized that I didn't really know the pulmonary anatomy. And so the video I'm presenting is based on our experience, which is about 900 thoracoscopic segmentectomies, anatomical segmentectomies. And the video is based on 3D models and intraoperative views. So I think specifically for the young surgeons, I think there are some pictures they can catch and that will help them to not only to understand the anatomy, but mainly to understand all the anatomical variations. And as one of our colleagues said, there is no standard anatomy, there are only variations. And these variations are very important to know.
That's a very important point. At the segmental level, the variations are quite tricky sometimes. So really for beginners learning a segmentectomy, what are your personal tips for learning the anatomy other than just reading textbooks? Are there any specific things that a beginner should do?
Well, I think what they can understand from our video presentation is that the first tip is using as much as possible a 3D model and study this model preoperatively and intraoperatively. So of course, this has some constraint. This is sometimes it has some cost depending on the software you are using, but I think it's much better to use a preoperative model. So this is the first tip. But the second tip is that you cannot rely only on the 3D model, because sometimes even if you have a very good model, during the procedure you get lost. And the reason you get lost is that sometimes the model looks very much like the normal anatomy, but sometimes you have either fibrosis or lymph nodes that you didn't expect. And also there are some variations in the length and diameter of the bronchovascular elements between the model and the intraoperative views. So even if you have a good models, sometimes you don't know very well where you are. So that brings me to the third tip, is that even if you have a good model, good 3D model, you have to perform this procedure with an extensive dissection of the elements in the fissure, so that you have a very good exposure and clear view of all the vessels and bronchi. So just not rely on the 3D model, but perform a good dissection in the fissure. And I think for this surgery, there is no place for so-called fissure-less technique. This should be a fissure-based technique. And I hope this is something you can understand if you watch the video.
These are really very important tips for everybody. So you do emphasize this need for preoperative planning, and that is absolutely key. But as you just mentioned, very often intraoperatively, what you see on table can differ somewhat from the preoperative images. So do you have any specific tips for the intraoperative side? Are there any tools that you can use intraoperatively? For example, any on-screen imaging? Does 3D printing help? Are there any tools that might help that?
Well, I was expecting this question. I don't know if it's the place to show a few seconds of the technology we are using now. Of course, you can use 3D printing. This is sometimes we have been studying in the department. In my mind, it has many limitations. The first limitation of 3D printing model in the operating room is that so far as I know, you have no model that you can sterilize. So you have to put the 3D printing into a plastic bag or something similar, which is not convenient at all to look at during the operation. And if you are operating in a dark room, as we do, you have to light the room to see the 3D printing. So it's not perfect, but I think some surgeons like it, but I don't like it so much. But I think the real breakthrough now is the use of mixed reality with exposure of the model. And if I can share my screen, I don't know if it's possible during this webinar, but I can show you a few seconds of this technology we are evaluating in the operating room, which is really excellent because you have the model floating around you. And if you don't want the model anymore, you shut your head-mounted display, and that's quite nice. Do you want a few pictures? Or?
Can we allow sharing screen? No.
If not, no.
Okay. Okay. Okay, but together here tonight, we have such a wealth of experience. So I just want to ask the other speakers, what are your experiences with the preoperative and intraoperative visualizations? Do you have any of your own particular tips and tricks you can share?
Yeah. Hi, Alan. Thank you so much
Hi,
for the invitation. Thank you, CTSNet. It's an honor to be here with you tonight. And well, we've been using 3D reconstruction for a while. At least for the last 3 years, we've been developing this in our department. We try also the virtual reality glasses. I think it is a big breakthrough as well, because it helps us to not only plan, but also to teach residents. I think it's an incredible tool for teaching. And I totally agree with the planning, and particularly when we talk about segmentectomies with so many anatomic variations, definitely preoperative planning is even more relevant. And I'm really concerned about the increasing number of segmentectomies and with regards to the quality of these segmentectomies. And so, considering that most of the surgeons don't have such a big experience with segmentectomies, having a very thorough preoperative planning is, in my opinion, paramount. And my question to Dr. Gousseau, I think it is not only interesting for the vascular aspect of the planning, right, and bronchovascular aspect, but what is your opinion about the position of the nodule with regard to the intersegmental plane? Because I don't think that all the segmentectomies are the same. Do you use the preoperative planning to consider that and to even select patients for segmentectomies?
Absolutely, and you are absolutely right. One of the interests of a 3D model is that you can better plane the safety margins. And I just show you an example that is quite frequent, is a target nodule in segment 6 at the basis of segment 6. And you don't know exactly if you can perform just segmentectomy S6 or segmentectomy S6 plus S10, for example. And if you have a good 3D model, you can study the safety margin and select if you can perform one or segmentectomy or two segments, the removal of two segments. And you're right. I think one of the explanation about a higher rate of recurrence in some segmentectomies, like segment 6, as it was demonstrated a couple of months ago by an article in the Annals, is that maybe in segment 6, you have many nodules at the basis of segment 6 and that the margins were not sufficient. I'm not sure of it, but it might be an explanation.
Do you think in situations like the one you just mentioned, I know, Dominic, in your hospital, you use a lot of autofluorescence in design in green for demarcation. Do you think tools like that would help in situations like this?
Absolutely. And maybe you know this article coming from a Canadian team showing that when they use indocyanine green, they have larger safety margin than expected, and that has probably a role also in the reduction of local recurrences and survival.
I wonder if Jessica or Christopher, do you have any other observations?
From my point of view, as a relatively junior consultant surgeon, I really enjoy watching Professor Gousseau's video. It always strikes a lot of fear into my heart looking at all the variations I wasn't aware of before, and makes me a lot more afraid of doing segmentectomies, but I think they're highly, highly valuable with great references. For me, at this stage, doing some of the more simple segmentectomies, minimally invasively, what I found useful in terms of intraoperative location is that doing it robotically, at least for me, you can use a live bronchoscopy. So your anesthetist can go into the airway that you think you should be dividing, and turning that onto a firefly mode. You can see on live view, confirming that you got the correct segmental airway that you divided. That can be quite just a reassurance, if more than anything, and it's very cheap and easy to do. And of course, using ICG after you've divided the vessels to give you a better idea about the intersegmental plane, very straightforward and well described. So I think, you know, my preferred robotic approach, there are some advantages and some tips and tricks to look at the segmental anatomy.
Okay, so again, if you don't mind, in the interest of time, we'll just move on so we can have some more questions at the end. So our next speaker is Ricardo Terra from Brazil, and he has produced a fantastic video on the robotic technique for a lower lobe basal segmentectomy. So again, Ricardo, could you tell us briefly what tips the audience can learn from your video presentation?
Well, for sure. In our video, the main idea was to show how you can, in practice, use 3D reconstruction for a preoperative planning of rather complex segmentectomy, S9 is actually an extend segmentectomy. It is not an usual segmentectomy, and so anatomy is particularly interesting for that case. So during the procedure, we use TypePro so that we have the 3D reconstruction and the procedure we are performing in the same screen. This helps a lot, and so we can compare and make decisions during the procedure. And also, one of the purposes of this video was to show the robotic technique as technique. It's very good to dissect lymph nodes, and because of the 3D visualization and also the maneuverability of the instruments, we can perform easier dissection. So it's of course possible to perform all these by Vats, but I think in the video we see how this 3D visualization and dexterity of the instruments allows us to dissect and encircle the vessels and remove lymph nodes that are behind the vessels. And in my opinion, this is the greatest advantage of the robotic technique.
That's absolutely key. You mentioned there the advantage in the segmentectomies, because every time we talk about robotics, there's an age-old debate, isn't there, about Vats versus rats, and we've talked about this for over 10 years with lobectomy. But as we move into the era of segmentectomy, do you think the advantages that the robot gives you with segmentectomy, is that great enough nowadays that you can recommend robotics over conventional Vats?
I do believe that robotic surgery purpose is to make complex procedures easier, and so it is more democratic. So more people are able to perform very complex procedures. When we see like very experienced surgeons operating on very complex cases, it's always a very interesting procedure. And then when you got back to your hospital, in São Paulo, it is very hard to reproduce that. And so in my opinion, the dexterity, the 3D visualization allows us to perform these complex procedures in a more easier way. And so I think that's where we see the advantage. And when it comes to segmentectomies, because it is a little bit more complex than a regular lobectomy, so it's when you see the biggest advantage. And recently it was published by, I think, the MD Anderson group, the fact that when they increased the number of robotic procedures, they also increased the number of complex segmentectomies. And so the purpose of this robotic surgery will be to increase the minimal invasive program, adding on this more complex procedures.
Mm. So you mentioned the democratic aspect of it, but of course the counter argument, of course, is cost. I mean, that will limit the access to robotic surgery. Do you think that the advantages outweigh the costs in terms of finances?
Yeah, that's a very good question, and we see that many players are getting into the market right now, and so I do believe that costs will go down and better platforms will be developed once you have many players and competing. And so I think now cost is definitely an issue, but I think in short time we'll see that this won't be that an issue anymore. We saw the same thing with video surgery maybe 20 years ago.
Of course, we have in our midst Dominique Guissot, who is the master of Vats segmentectomy. So do you have any counter opinions, Dominique?
Yes, little bit. In the department, we are using both Vats and rats. I must say, I must be, maybe I stay in the middle age, so I'm using only Vats, not rats, but my colleagues are using rats, but they do both. They, depending on different points, they use either Vats or rats. The issue is when we are comparing VATS and rats is that we are very frequently comparing apples to oranges. I mean, it depends how you perform that. So in the department, we are using a multiportal approach with dedicated instruments that have been specifically designed for VATS. They are very thin, very sharp. We have a robotized scope holder, so there is no issue of camera shaking and things like that. So it's very close to rats, although, of course, we don't have the degrees of freedom of the instruments. Otherwise, you can perform a very accurate dissection with rats and VATS. So I think this is, it's, in my opinion, it's wrong to say that you do it better by rats. You do it more comfortably, no doubt about this. It's more comfortable for the surgeons. But if the results, your results are better by rats than VATS, it means probably that something is wrong with your VATS technique or VATS equipment.
Jessica, do you have any comments?
I feel like I don't belong at this table with these masters. I'm here to be
You are a master.
if I can do it, anyone can do it. But I agree. I think doing good complex segments is just dedicated to taking the time to do it. And it does mean when you're working on complex segments that there will be times that you can't just do an S9, S10 and you have to extend what you're doing while your learning curve is going. But I think you have to have a plan in your head as a young surgeon learning these techniques when you're at the point when you can't make this work anymore minimally invasively. Is my plan that I need to open because that's what I need to do, or is my plan that I need to do a bigger resection? But I think we all need to challenge ourselves with these procedures and to keep working, because I think this is where the field is going. But good preparation makes a huge difference, and watching how a master gets around some of these technical challenges so that you can foresee it as you're starting this is really important.
So true. Chris, I know you have a lot of robotic experience of segmentectomies. What's your view? Is it the approach of choice, do you think?
Well, look, I think it's from my personal point of view, I'm going to have to agree with Ricardo there. I think just with the robot, once you get comfortable with it, certainly at least for the surgeon's perspective, it's much easier to do aggressive and one lymph nodal dissections and to take the whole lymph node in its entirety to get right on top of that capsule, keep the capsule intact and to take the whole node out and do that reproducibly and to get around individual structures. I feel like using the robot, it's much, I feel much more comfortable with it. But that is to say, I've seen very good master VATS surgeons who are able to achieve the same goals, but they obviously just have a higher skill set to make the same results.
Yeah. So for the audience out there, we're very privileged in this series on CTSNet to have some of the videos that we're talking about, including by Diego himself using the classic uniportal VATS approach. So please watch all the videos and decide for yourselves which is the best technique for you. We're getting some questions in the Q&A, so we'll try and save some time at the end of this session for that. So we'll move this conversation along, if that's okay. And I'd like to move on to our fourth speaker, Professor Jessica Donnington, a fantastic speaker. So we've given you the very important task of wrapping up the video series with a concluding video, which I think is one of the very keys to understanding segmentectomy. So could you again tell our viewers what to expect from your video presentation?
So my video goes through a little bit of just deciding how and when to use a segmentectomy, and also into understanding the subtlety of the science and the subtlety of the language of using segments. Why was the JCOG trial and the Calgb trial so important? Because retrospective data could never cover all the nuances that go into these decisions. You know, from elective versus a compromised operation to, you know, how solid or how ground glass the nodules are, to margins, to size, to lymph nodes. There's just so much that goes into deciding who gets a segment and when they get it and how they do it. And I think all of that really needed prospective data for us to really accept that we were not comparing apples to oranges in all of our trials. I think the rigor of how we choose our segments and how we do them is really important, because there are, competing technologies which are very similar to a wedge resection. And the value of our resection over something like SBRT or cryoablation will be, margin distance and lymph nodes. And I think those are the things that segments provide to us. And so I think it's a very, I think these are really important trials that will move our field forward. But I think we have to look back and remember what makes these better than just an ablative therapy.
Yeah, that last point you mentioned is so important, because as you say, there are serious challenges to surgeons in the form of ablative therapy, external beam radiation therapies. So do you see in the coming years, is this segmentectomy versus ablation versus radiation therapy, is this a zero-sum game? Does one win out over the other, or is there some kind of room for these different approaches to coexist?
I mean, lung cancer is a huge disease. There's always going to be room for all of us to exist. There's no doubt about it. And there are a lot of people with lung cancer who are quite compromised. And I mean, when we look at what's made lung cancer survival better, I mean, we do have all the exciting new technologies in stage 4. But the reality is, one reason lung cancer survival is better is that we have treatments for people with local disease who used to get nothing. And now they get SBRT, and guess what? They live more years. So I think there will always be room. I think our realm should be in those patients who are, otherwise healthy. I do think we have a much greater promise for longer survival than someone who receives SBRT. But some of that, again, I think is tied to the extent of our resections and the ability to collect lymph nodes. I think one of our greatest threats might come from endoscopic ablative therapy. There is a chance that our IP doctors could become the next interventional cardiologists, that the patients come to them and never get a discussion with anyone else before the treatment starts. And that's going to take good data from our side to make sure that doesn't happen.
As you say, we are moving into a very exciting era in lung cancer therapy, when there are so many different things happening at the same time as segmentectomy. So we've got lung cancer screening, we've got a greater appreciation of subgroups such as the multifocal non-small cell lung cancers, the oligometastatic stage 4 diseases, and of course nowadays we have multimodality treatments that combine surgery with advanced TKI or immunotherapies. So in this context of all these different developments going on, how do you see segmentectomy itself fitting in to the overall sort of the algorithm of lung cancer management strategies?
Well, again, I think with screening, segmentectomy should become more and more common. The goal of segmentectomy is the goal of screening is to find tumors that are in that 1 centimeter, 2 centimeter range. And it would be, I think, unfortunate if all of those turned into lobectomies. I just don't think that is, that's a jackhammer to a fly. Is that the statement, like more treatment than patients sometimes need? The other settings are going to be interesting. I mean, there's no doubt about it that local consolidative therapy is more and more a part of how we treat oligometastatic lung cancer, and surgery hasn't totally been engaged there. And would that really be a segment, or is that something that really stays in the realm of lobectomy? I don't know, but that is one of the interesting questions going forward as we become a bigger part of stage 4 treatment too.
So can I bring in our other speakers into this conversation? So as we move into this era of screening and multimodality treatment, has segmentectomy per se affected your care for your patients, do you think? So maybe Dominique, would you like to start?
Well, I think what has just been said is very important, but I think we are surgeons, so probably we are all convinced that removing the nodule or the tumor is better than, for instance, SBRT. But of course, the people who are performing SBRT, they say that SBRT is better, not only because they have good survival, but because they don't kill patients. And the morbidity, although there is some morbidity, is quite low. So I think that our goal for the future is twofold. One is to reduce the mortality and morbidity of our procedures. And for that, it's very important to perform true anatomical resection with accuracy, because if you have a better accuracy, you have less morbidity. And the second arm of this is that maybe in the future, we don't have to be too much dogmatic and choose which patient should have a segmentectomy and which patient maybe because he's old or he has comorbidities should have a wedge resection. Why not? And we have to adapt our technique to the patient and choose the best alternate treatment.
Ricardo, what do you think? Has segmentectomy, how does that change your practice?
Oh yeah, we've been performing more segmentectomies lately, and we've been diagnosing patients earlier. And I think that COVID-19, one of the things was the fact that all patients had CT scans, and we were able to detect so many, early cases. But I'd like to make an additional comment with regard to what Dr. Gonzalez said. I think that personalized medicine will probably also increase the selection of patients for one procedure or other. And when it comes to having like the details of the tumor and the mutations, and we understand how these mutations will come into play in the course of the disease, I think we'll be able to better select patients for different procedures, not only segmentectomy, but maybe some, cancers will be more radio sensitive and so we'll be able to select better patients for one procedure or the other.
Christopher?
I think the value of the pathology will increase. I think that's something that's working for surgery as opposed to SBRT. I think it's good to know what you're treating and each individual patient's particular mutations, and also the nodal status. I think that'll become more and more important. That's something that we always have advantage over radiotherapy. In my personal practice, I think, with lung cancer screening, and particularly with a somewhat Asian population patients that I see, you see more and more of these GGOs. And I think that's one end of the spectrum where I'm starting to do more segmentectomies. And then the other end, the compromised patients, that's become very much an accepted sort of almost standard of care for patients who can't tolerate a lobectomy. I think it's very important to educate our peers what a true segmentectomy is, not just junior surgeons, but also I think respiratory physicians and medical oncologists, and many of whom don't know the nuances and the subtle differences between something that'll take you 20 minutes versus something that'll take you 2 hours. And it's very important for them to understand that extra centimeter of margin and those N1 nodes that you take out is worth the effort.
That's so true. Okay, so I'm itching to go on to the Q&A sessions. We've got a few questions in the Q&A, but before we move on to that, I think the one burning issue that we must cover is the Calgb 140503 trial just announced this week. And for those in the audience who don't know, at the World Lung Cancer Conference in Vienna just this week, Nasser Al-Turki presented the results of the American randomized controlled trial comparing sublobar resection to lobar resection for these small lung cancers. And cut a long story short, the conclusion was no statistical difference. So this further corroborates the JCOG results. So I want to open this to all our speakers. What are your views on these results? Is this a game changer? So Jessica, do you want to start?
I do think it's a game changer in terms of the use of sublobar resection. The one major difference between the Calgb trial and the JCOG trial was the inclusion of wedge resection and not just segmentectomy. And I think it was 58.8% of patients or something got a wedge. That being said, the randomization to lobar versus sublobar resection was after lymph node evaluation. Not all the, intralobar lymph nodes needed to be evaluated, but the mediastinum did need to be before the randomization. So that was an important take home. But I do think it does raise some questions about, is a wedge as good as a segment? I think a lot of us who really see segments as really anatomic resections with, lymph node collections as good as our lobectomies or even better, really question what will be the rigor of this procedure going forward or this information? Because I think there is some risk there that people will think that a simple wedge with an EBUS beforehand is the same thing as what was demonstrated in this trial.
So true. Ricardo, any comments?
Yeah, I do agree. I think it is a game changer. And of course, having in different populations similar results is very good. And so it confirms the findings of JCOG. My main issue is with regards to implementation of this in clinical practice, how this will play out, and how people will really interpret the data. As Dr. Donnington said, we are concerned about, just thinking that edges are equivalent. We don't know that yet. And I also think it comes out many questions with regards to the details of the segmentectomy. I think that we have to move forward this, like where the nodule is, as we have already talked a little bit about this, and what is if the segment interferes, the margin, the adequate margin. I think that we have to move forward with this sort of questions as well.
So true. Dominique?
No, I'm very much surprised. I'm waiting for details. It's very difficult for me to understand that a wedge is similar to an anatomical segmentectomy. So I prefer to wait viewing the details.
So
I mean, it's known for years. It's known for years that with wedge resections you have many local recurrences. So why should it be different?
Yeah. That's such an important message you said, because I think a lot of people might take the wrong take-home message from this, that the wedge resection is equivalent, isn't it? Yeah. So Chris, do you think this CALGB trial addresses some of the limitations of the previous existing evidence?
I have to say, as I said earlier, I think it may have posed more questions than answers. I think its supporting evidence of the JCOG is, I think, overtaken by the number of questions you may ask. I mean, is the onus now on dedicated thoracic surgeons to prove that a segmentectomy is superior to a wedge resection? I mean, are people going to use this new data and weaponize the justification of doing very simple procedures for patients with peripheral small lung cancers? And do we have now proof that what we believe that wider margins nodal dissection is actually going to make a difference? If so, that's going to be a very difficult task, because I, for one, would not have the clinical equipoise to randomize patients to the wedge treatment arm. And the second thing is, what if they're right? What if in very, very carefully selected patients who have undergone very rigorous preoperative imaging, like very dedicated PET and CT and EBUS, what if that doesn't make a difference? What if a wide wedge is very similar to a segmentectomy? I mean, I don't believe so, but you have to be provocative and think, where is the evidence for that?
That's so true. As you said, yeah.
No, this is what I say, that we must not reject wedge. Probably there are good indications for wedge in some patients with comorbidities.
Yeah, so for
but
those in
treating
the
all
audience,
the patients by wedge looks very strange to me.
I completely agree with you, but I am afraid of people misusing the data or misinterpreting the data from the CALGB to justify a much simpler operation. I think that's of a big concern around the world, not just in the States. people are already asking me, hey, is a wedge the same as a lobectomy? That's what's being tweeted, or that's what I heard last week. It's a lot of them will take a lot of education to understand this relatively subtle differences between a true segment and a wedge, for non-surgical physicians especially.
Yeah, that's such an important thing. I think all our speakers have brought up. Don't just read the conclusion slide and then go ahead and do wedge resections. Pay attention to the details of the study. The nuances are what's critical here. So let's move on to the questions. We've got some good questions from the audience. So our first question is from Alejandro Briesco. Sorry if I mispronounced your name. He thanks everybody for our earlier discussion on the JCOG 0802. And he asks, could the speakers comment on one, the use or possible use of sentinel lymph node mapping during anatomic resection? And two, what's the concept of identifying STAS intraoperatively when you do a segmentectomy? So our speakers, any takers? Yeah, Jessica, it's you.
We're all stymied. We're all like, we're waiting for someone else to give us insight. So I think STAS is hard. I guess I was hoping Dominique might give us some insight. When the pathology report comes back and you find STAS, or you do find an intralobar lymph node, does anyone on this panel go back and consider a completion lobectomy?
Well, first, I'm not aware that STAS could be studied during the procedure intraoperatively. I don't think so. So probably there is STAS on the final pathological results. No, I will not reoperate to the patients. As far as I know, there are 2 studies about STAS when you perform lobectomy, segmentectomy, and wedges, and the only difference is when you perform a wedge. Apparently, there is no difference in survival if you perform a lobectomy or a segmentectomy. The only difference is with a wedge. Otherwise, the other aspect of the question is, do you reoperate on the patient if there is a positive lymph node or a positive margin? I think you should reoperate. Unfortunately, usually you get the results 1 week or 2 weeks after the discharge of the patients, and you don't. And this is one reason for me to make this study intraoperatively, so that you can switch to a lobectomy if necessary. I mean, it's not a matter of wasting 20 minutes or 30 minutes. I mean, it's the life and survival of the patient.
Does anybody have any views on the sentinel lymph node issue?
It's been very challenging technology in lung cancer. Maybe as our expertise does grow and we get more comfortable with those intralobar lymph nodes, it will have greater use, but we are still quite a ways away, I think.
Yeah, absolutely. I think we've been talking about sentinel lymph nodes in the context of a lobectomy for so many years, and we really haven't reached a conclusion. I think to reach a conclusion regarding sentinel lymph nodes and segmentectomy, that's going to take even longer. I think that's something that we need further data on. But so Dominique, we were talking about conversion. So, and one question from Arthur Matella in the audience is how often do intraoperative findings result in conversion from a segmentectomy to a lobectomy? What are the indications to do a lobectomy nowadays?
Should I answer the question?
Yeah, please.
Well, 3 or 4 years ago, we published a paper in the Annals with our results. It was only about 300 patients, but on the 300 patients, we had a couple of conversions, either for positive lymph nodes or for positive margins. And what was interesting is that sometimes the surgeons thought he had very good margins, but the pathologist said intraoperatively, well, it's doubtful. I think there are a few cells around, and so the procedure was extended to lobectomy. So we had around 10 patients that had finally a lobectomy because of invaded or doubtful margin, and 3 patients with positive lymph nodes. Very recently, we had patients with a very tiny nodule, a CT1A N0 which was finally N1. So this is quite frequent.
So your comment about margins is quite important. So do you routinely do frozen sections to look at the margins in all your segmentectomies?
Not routinely. I mean, if you have a 4 centimeter margin, of course, we don't ask the pathologist to examine. But if it's a matter of 1.5 or 2 centimeters, we ask the pathologist not to examine all the staple line, but we put 2 stitches facing the tumor and said, well, could you please study this length of the margin? Yes, we do that in all our patients.
So Ricardo, Christopher, do you have any other comments about conversion to lobectomy?
I actually have one question to Dr. Gosho with regards to that paper. Sometimes it's quite difficult to have margins when the lesion is more central. Did you have any conversion because of that? Because sometimes, even though you can see that the nodule is in the segment, but when it's too central, sometimes it's quite tricky to really remove it with adequate margins. Do you have any comments on that?
Well, the case you are describing is probably a case that should have a lobectomy, no?
So,
yeah.
On that note, we have another question here asking about lobectomy. Is pleural invasion an indication for switching to a lobectomy?
So just go back to the previous question. I think the JCOG study did show about 22 conversions from intended segment to lobe. So roughly works about 4.5%. Pleural invasion, oftentimes only find out after the formal pathology has come back, and so I think that similar to STAS, you don't really get reliable intraoperative assessment.
Very important. So while we're with you, Chris, I think we have a question from Hidemi Suzuki. He says, do you think it's possible or necessary to do a meta-analysis combining the JCOG and CLGB data?
Possible, yes. Possible, yes. Necessary, absolutely not. It's not really statistically appropriate to meta-analyze 2 or even 3 randomized controlled trials. Possible, absolutely yes. But with such little data from just 2 relevant trials, in my opinion, it's more important to study those closely rather than just giving a statistical summary of those 2.
Yeah, but do you think the cohorts are too different that any kind of pooled analysis might
be? Yeah, exactly
right.
The heterogeneity will be huge. And I think even from a enthusiastic person without meta-analysis, I don't think it's very appropriate in this particular case.
Okay, fantastic. I think we've run up to the end of our allotted hour. I think I want to thank everybody once again. We're really privileged here today to have such world-renowned speakers here today, and I think the conversation has been outstanding. I hope everybody in the audience appreciates it and will rewatch this webinar in years ahead. So with that, I'll hand the time back to our host, CTSNet, to wrap this up. Thank you so much.
Thank you.
Thanks, everyone. Thanks, Alan.
Thank you. Thank you. Okay.
Thank you for attending the CTSNet webinar. You can check out Alan's full guest editor series on segmentectomy for lung cancer at ctsnet.org, along with hundreds of additional cardiothoracic surgery videos. As a reminder, a recording of today's webinar will be available next Monday on ctsnet.org and CTSNet's YouTube channel. To stay up to date with the latest CTSNet content and be an active part of the online global cardiothoracic community, be sure to create or update your CTSNet profile today.
Okay, so thank you and have a good day, everybody. Bye-bye.
Thank you, Alan.
Thank you so much. Thank you, all of you.